All right, Terry, whenever you're ready.
Okay. Hello, everyone. Thank you so much for joining us today. For those of you on the call that don't know me, I'm Terry Shields, and I'm a nurse and the state coordinator for the CARES Registry, collecting data on out-of-hospital cardiac arrest. I'm also the executive director of Save My Heart, Michigan's statewide initiative to improve survival from cardiac arrest. I would love to welcome you all today to our out-of-hospital cardiac arrest learning community special webinar on COVID-19. Now more than ever, it seems important to share information on our experiences to better be prepared and build stronger communities and pre-hospital systems. The learning community engages a multi-stakeholder approach to a learning cycle and to change behaviors, improve outcomes. And on the call today, we have a diverse group of first responders, EMS, hospital providers, educators, and others interested in improving cardiac arrest survival. So I'm very excited to get this meeting started. And now we're going to quickly go over a few items regarding the meeting format. This meeting will be recorded, and your attendance to consent is your being on the meeting to be recorded. The recording of this meeting will be on the Learning Community website. Please use the chat box feature to ask questions or make comments, and we'll address all the questions in a single session following the final presentation. This is the agenda for today's webinar, and I am pleased to introduce our first speaker, Dr. Thomas Ray. Dr. Ray is a highly regarded medical director for King County EMS in Seattle and professor of medicine at the University of Washington and Harborview Medical Center. Dr. Ray has published widely on cardiac arrest and resuscitation and is very involved in pre-hospital emergency care for cardiac arrest. He's the director of the Heart Rescue Program, which aims to improve survival in participating states and communities. Dr. Ray received his medical degree from the University of Michigan. Welcome, Dr. Ray. We're so excited to have you speak to us today. Tom?
Yeah, so I'm going to try to share my screen here and see how that goes. So can you see my screen, Terry?
Looks good, yep.
Okay, so thanks very much for the invitation. I will give you a perspective on COVID from the Pacific Northwest and what's unfolded here in our region, how we've tried and sometimes succeeded to help manage this pandemic as part of the bigger public health effort here in Seattle and King County, and to some extent, Washington State. So as Terry said, I'm the EMS medical director for King County. And I work closely with a number of colleagues, and I'll highlight some of those collaborations and working partnerships in the next 15 or 20 minutes. So what am I going to talk about? Let's see here if I can advance the slides. There we go. So I'll talk about the first few days and how it unfolded. I'll talk about some of the critical structure and strategies that I think have been very important for us to have some success. I'll talk about healthcare worker safety, some of our efforts to monitor the system, and finally turn to clinical matters and talk a bit about resuscitation. So first, very important to acknowledge all the folks. I'm gonna speak this morning, but there's a team of us really, like any group that have helped here, and this is the medical leadership. And some of these names you may recognize: Dr. Sayer, who's the medical director for the Seattle Fire Department; Pete Kudenchuk, who's a prolific researcher and also one of the EMS medical directors. Jeff Duchin on the lower left is actually our medical officer for King County Public Health and has been instrumental in some of the work we've done. And then the two in the middle, Betty Yang and David Murphy, are EMS fellows. Andy McCoy is an EMS medical director. Everyone knows and loves Mickey Eisenberg. And then Patty Hayes is the Director of Public Health here in King County. So credit goes to all those folks. So just some background about King County. It is a large county, about 2,200 square miles, over 2 million persons. Seattle's the largest city, but there are actually a dozen cities that have over 50,000 people. So it's a It's a fairly diverse geographic and socioeconomic region. Our EMS system is administered by public health, and that's been important. We have primary response is provided by 27 fire departments. We're two-tier, so we definitely rely on our BLS EMT providers, and then we have an overarching ALS paramedic response as well. And we have 4 communication centers, and we have 12 primary receiving hospitals. So if I go back to February 28th, it really, the morning of the 28th anyway, it felt like this pandemic was far, far away. I mean, we had a case that had come through the Seattle-Tacoma airport, which is here in King County, back in January, but it seemingly come and gone. The person lived to the county to the north. He'd been hospitalized, and extensive measures had been taken to isolate that individual. And so we felt pretty comfortable for the most part on the morning of the 28th. In fact, this was a typical day here in the Pacific Northwest. If you drive about 30 miles east of Seattle, you hit the snow, hit the mountains, and many were sort of headed for the mountains on that Friday to go skiing. Dr. Sayer and I felt pretty good about ourselves. We had just updated our COVID-19 criteria for our EMS providers, which required a constellation of symptoms, febrile respiratory illness, and then some epidemiologic risk factors, typically travel from a high-risk endemic location or a known contact. And then we did note, right, that this new criteria had come along, right, which is this unexplained lung illness, which was really just published that last week of February, and was a key piece of information for our hospitals who identified this first, what we might call domestic case of COVID-19. So then we transitioned to the evening of February 28th, and it was a peaceful evening like we enjoy here in the Pacific Northwest. And about 8:30 in the evening, I got a call from Evergreen Medical Center, which is the hospital that's up in the northeast portion of King County. It's an excellent facility and does very good work. And their infection control officer called me to say, they had sent off a couple of swabs under this criteria of unexplained severe respiratory illness. They had a couple of older patients in the ICU that weren't getting better, and they didn't know what was going on, so they sent these off several days ago, right? So again, remember, testing at that time took 5, 6, 7 days. It was a send out, and they'd just gotten the test results back, and they were positive. And he wondered if there had been any contact with EMS among those 2 patients. Well, so we did our homework and went back and looked, and indeed, those 2 individuals had come from this life care center in Kirkland that I think many of you have heard about. And it led to a very active response. And some of this is, in hindsight, I can't explain why we did everything the way we did it. But in many ways, we were fortunate to have some very smart people in the fire department and at the local government level who appreciated the magnitude and gravity of this situation. And so that night, between the hours of 9 p.m. and 2, 3 in the morning, we spun up a lot of services. We realized actually we had thought there was a flu outbreak in that facility. We quickly realized this wasn't the influenza, but instead coronavirus. And so we tracked and appreciated there had actually been dozens of calls to that facility, again, under the understanding that we thought that this had been flu. And there had been an outreach by public health to the facility to try earlier on in the week and alert them about the flu and what steps they could take. Well, all of those efforts, although useful, sort of went out the window. And we spent the night trying to track down all the calls, all the individuals, make a list of who had been there, and then quickly quarantine them, right? And so we were doing this sort of flying the plane and building the plane at the same time. And so I just ask, it may not seem smooth and elegant to everybody, but understand we were sort of writing the manual as we did this. We had a pandemic plan in King County, but some of the specifics and the operations really had to get informed in the moment as this went forward. So if we jump ahead just a couple of days, and that weekend was a whirlwind for sure, but just a couple of days in, then we now had 20 cases here in King County and 8 deaths. And we were really, I think, we appreciated that this was going to be a big deal because of the high case mortality that we were observing among the people who were infected. So let me then move on beyond those first few days and talk about what were, I think, some critical strategies. And not surprisingly, it really is this issue of communication. And this has proven to be, I think, our biggest asset here in King County. So that Saturday morning, I kind of wandered into public health. I wasn't exactly sure where I should go, but I knew that public health leaders would be at the public health building downtown. And so I said, well, we're part of public health. I better get down there. And indeed, there were probably initially half a dozen and then a dozen. And it really became the focus. And so from that point on, there was a daily meeting with public health that brought together prevention, local and regional government, many folks, and it was really just an excellent forum to hear what was going on and then to provide input regarding EMS. EMS actually had quite a bit to offer in these early stages. So what I would say is that communication is critical and key, and I think everyone understands this. We had these daily meetings at Public Health. We still have them. They've been scaled back to the Monday, Wednesday, Fridays, but the interface, it provided an interface with the local public health, the hospitals, state Department of Health, government, and ultimately the CDC. The CDC arrived on that Monday after the Friday announcement of that case. So they were integral and really quite helpful in how to manage and help that initial outbreak. We also had the good fortune to interface with the University of Washington and infection. So we were able to listen and participate with public health and then try to understand how it might involve EMS, what we should be doing for our workforce, and bounce ideas off of the experts in academic medicine. And so having that avenue was also quite helpful. We then sort of pivoted 180 degrees, and Dr. Sayer, myself, and a few others from EMS would communicate daily with the fire chiefs. And so we had a 3 o'clock call. We still have a 3 o'clock call with the fire chiefs. Again, there are 27 fire departments and a number of EMS stakeholders, right? We have private ambulance companies, hospitals, and other folks involved. And so that phone call, which now occurs Monday, Wednesday, and Friday, involves usually somewhere between 50 and 75 stakeholders. And then the other important aspect here was to have a clearinghouse of information that was vetted, valid, and sort of official. And so it took probably a week or so to get our mojo on this, but we ultimately landed on the King County Fire Chiefs Association website, and there's the link there. And it's an open access website. I would encourage you to go and look at some of the resources. It may or may not be useful to you, but it really has been an excellent avenue for folks to get information in our region on how to manage COVID. All right, so when we think about all the things that public health was responsible for, it was really helpful for us to be at the table, sometimes just to actively listen and understand all the domains that they were trying to manage here, right? And again, I won't list each of these, but you can see on the screen all the things that they were actively involved in, and many of them interfaced with EMS. And it was helpful for us to learn, listen, and then sometimes participate with the larger public health strategy. So the epidemiology here, right? I think the epidemiology is different in every region probably, but there are some common themes. In our community, it was really the long-term care facilities and healthcare workers who in some ways were the vector for this illness in our system. And so the CDC, along with many of us, worked to try to understand some of the epidemiology here, and we published this article now 6 or 8 weeks ago. And you can see they traced how this went from one skilled nursing facility to another, and to another. And you know, early on, it was the purview of the skilled nursing facility before it became sort of community-based transmission. And we were able to sort of backtrack and understand how it went from one to the other to the other. So in thinking about this, right, Dr. Sayer and I are so proud of our updated guideline, which really focused on, well, had you traveled from an endemic area and had a known contact and had a febrile respiratory illness? Well, it turns out that really wasn't very helpful. And so it led to a lot of efforts to be nimble. And again, I ask for your forgiveness, understanding we were sort of doing this in real time, given that we were one of the early regions for this illness here in the US. So on to healthcare worker safety. With that original guideline from the CDC on how to screen and risk stratify. So I'm going to talk a bit about EMS deployment, case detection and surveillance, and our exposure quarantine and isolation, and then wellness and testing. So what you see there is one of our paramedics, and this is our PPE in its fullest form, right, which is an N95, eye protection, gown, and gloves. And that is essentially what we do. If we do aerosolizing procedure, we will put on a face shield as well. And this is basically what we've used throughout King County. So a couple of things that I think are important to understand what we've been able to do here, right? So we are part of public health, and so we have direct access to the state and local surveillance for COVID testing. And so every day we do an electronic and then manual link of all our EMS encounters with our COVID surveillance data to understand when EMS was involved with the COVID patient. And initially it was sort of hit or miss, but I think it's become more and more robust, and that the testing has turned around much more quickly now. And so we think it's usually we learn about exposures or encounters the next day if EMS wasn't already aware. So the next slide is busy, but I think it's important, and it highlights our encounters with COVID patients from EMS. And so this leveraged that strategy to do that linking. And what you can see is on the x-axis is calendar time, and on the y-axis, at least on the left, is the number of providers that had an EMS encounter with a COVID patient on a given day here in King County. So again, understand we've got a fairly big county. We have over 500 EMS calls a day. And you can see that at its peak, we had almost 90 EMS providers on a given day engage with a patient who had COVID. So those are the light blue bars. And then the dark blue part of those bars is an actual exposure, right? And we defined exposure based on the CDC definition. So we would go and we would do the link, understand if there was an encounter, and then we would read the report, and we would see if there was potentially an exposure. And each fire department has a health officer, and they would reach out to the crew, inform them that, hey, that was indeed a COVID patient, as you did or did not suspect. And you've documented your PPE, but hey, you didn't document that you were wearing your mask. Were you wearing a mask? And the answer is no. Well, I spent 30 minutes with that patient in the back of an ambulance without a mask. Well, that was an exposure, and that's a dark blue bar. And so I think you can see visually that over time, the dark blue bars have essentially gone to zero. So we've had less and less exposure. And that's, I think, due to a number of factors. So the first is we've obviously we've expanded our criteria for what represents a potential COVID patient, right? So we initially expanded to specific locations, and then now all sort of long-term care facilities are on that high-risk dispatch call-out. And then we've also expanded our symptoms, right? It's not a febrile respiratory illness, but it's fever or acute respiratory symptoms, or quite honestly, it can be, as we've all understood, a heterogeneous collection, and it requires some, I think, provider in the field assessment. make that happen. So we've actually gone to what we call a scout method, which is where we send in one, sometimes two first responders in full gear to assess the situation and let folks know whether the rest of the crew needs to don their PPE or not. Now, we can only obviously do this in lower acuity calls. We don't do this in cardiac arrest. Cardiac arrest, everyone automatically dons their full PPE and in we go as quickly as possible. But this method has, I think, helped us reduce our actual COVID exposures and conserve PPE. So if every provider wore PPE to every call, we would burn through something on the order of 30,000 units of PPE a week. And right now we use about 9,000 units. So you can see we've been able to use substantially less PPE had we sort of blanketly responded in full PPE, all providers on all calls. So that's a complicated slide, but I think it's important and highlights some of our efforts to be responsive and be responsible with our PPE. All right, this just shows, again, the total number of COVID encounters, and you can see it peaked in the middle of, or the beginning of April, really end of March, and it is declining here in King County, which is helpful. But that decline has been slow. And so we continue to monitor this. This is an activity to link and to understand how often EMS encounters COVID patients. So we have an exposure, quarantine, isolation, return to work plan. This has been informed again by the University of Washington, by the DOH, and by our public health officer, Jeff Duchin. I won't go into the details here. It is on the website, and certainly you can have take a look and ask questions. We've also done wellness screening, and I think this has been quite helpful. Again, understand that this went forward. The idea is early in March, and it required involvement and a little bit of negotiation with labor as to what this would mean. But the fire departments really saw the benefits and how this could help their workforce stay healthy. And so we now do wellness screens, I think, like most organizations do when folks first show up to work. We try to do it in an efficient way that doesn't expose others and keeps them out of the workplace until they've attested to their good health that day. The other thing we've done here, which has been, I think, useful and responsive to our EMS and other public safety providers. And a lot of credit here goes to Dr. Sayer and to the Seattle Fire Department, who led the charge, and then other agencies in King County followed close behind. But that's the idea of COVID-19 testing for public safety. So we actually got a special allowance from the state to have EMTs and paramedics do these procedures. And we stood up 3 different testing sites that were initially dedicated to first response, to include law enforcement, to include private ambulance and public safety. So we operate these testing sites across King County that prioritize first response as a way to support the workforce and help them understand whether their illness is potentially COVID or whether it's something different. So, here's just a shot of these drive-in sites. Again, one in the north end of the county, one in the city of Seattle, and one in the south east part of the county. And we have a dashboard for that. And again, to date, I think we're now up to about 750 tested. Seattle was out of the gate first and really, again, did a fine example of testing all the details. And then the other 2 sites have followed suit. And again, you can see in the upper right that a whole host of different agencies have taken part and used that facility, whether it be the law enforcement or EMS. The rate of positivity has declined over time as the rate of illness in the community has also declined. But it's been a really wonderful service. It's gotten people back to work quicker. And I think when you do the cost analysis, it probably will be cost effective, if not cost savings for our system. All right, system monitoring, briefly. So public health early on here in King County set up some dashboards, and we thought these dashboards were good ideas, and we said we need to do something similar for EMS, and so have worked to do something along these lines. And you can go to the King County Public Health website and look at the COVID-19 dashboards. Currently they have 4 and they're getting ready to launch a 5th. Here's an example of one of their web pages, which just shows where the cases are coming from and sort of over time what the cases are doing in terms of case count. So that's very helpful. They're interactive and you can use those to understand what's going on in the community. So we followed that with our own EMS system monitoring. Again, I think many of us are doing this. We have seen, we initially saw a substantial decline in calls, probably 25% overall. You can see that, and it's now beginning to build again. There's been a lot of messaging not to stay at home if you've got a cardiovascular emergency, but rather call 911, that it's safe. And so we worked hard to get that message out. The lower panels just show who did the primary transport or whether it involved an ALS provider. So we look at the stress to the system and we map that stress. Again, this is the number of calls per fire department on an incidence basis, so per 1,000 residents. We also map and do a dashboard of our PPE use, right? So several of the electronic formats require or can require that you document your PPE use, and we've implemented those requirements to close out records, and it's been incredibly helpful as we coordinate with public health and the state to access. They really want an inventory of what we're using and why we're using it. All right, last and not least, cardiac arrest resuscitation. So I first of all want to acknowledge and call out the fine work by the American Heart Association. And so they really worked hard to be responsive and to try to wade into what is a really difficult topic of how do you do resuscitation during the pandemic. And I appreciate there's all kinds of different perspectives on this issue. And so we've had to look and read critically and understand whether we think the new guidelines, the interim guidelines as they call them, are useful for our region. So in that guideline document, they say, they have statements, and I'm paraphrasing here, bystander CPR improves the likelihood of survival, which decreases with every minute that CPR is delayed. And I agree with that statement. They then go on to comment that telecommunicators should screen for COVID-19 symptoms, known COVID infection, or recent COVID contact. And then suggest that face masks covering the mouth and nose of the rescuer or the patient may reduce transmission risk. So, you know, the second and third statement really mitigate that first statement. And so we really have had heartburn over this and wanted to understand really whether if we ask our telecommunicators to ask these questions and then suggest these actions to the rescuers, we really think we're going to undermine bystander CPR. And so we wanted to be understand really whether this was something we should move forward with or not. And so what we've tried to do over the last few weeks is understand what's the prevalence of COVID in our community and how often would this action really be relevant. You know, how often is COVID involved in cardiac arrest? You hear all kinds of estimates depending on where you are and what community you're in. So this is a graphic. It's very preliminary, and I would ask that we don't share this widely, this one slide, because it is preliminary and we're still working on it. But you can see the number of COVID cases. So lab confirmed is in red, and the orange is ones that we reviewed all of these to understand whether there were any febrile or respiratory symptoms beforehand, doing our best to classify clinically if there wasn't lab testing. And so from that first death due to COVID, which was late in February, we see COVID prevalence in cardiac arrest at about 5%. And so from our perspective, to institute this type of directive, you know, for 5% for a theoretical rescuer protection, which again, I understand there will be debate on this topic. We're not convinced that this is going to help public health, and we know it's going to hurt bystander CPR in our region. Over half of our CPR comes as a consequence of telecommunicators CPR. So we have stuck with this. The telecommunicator asks if the patient's conscious and breathing normally, no and no, and they launch into, well, we need to start CPR and I can help you. And so we haven't changed those questions. So I will stop at that point, Terry, and move on with the program for this morning. Thank you very much for your attention.
Great. Thank you so much, Dr. Ray. That was an excellent presentation, and we will hold questions to the end of all the speakers. So if you want to start chatting, we'll monitor that. So, you know, I know it probably wasn't very comfortable being in the spotlight, but King County, you guys have an excellent system of care there. So thank you for sharing all that detailed information. Now we're going to get a perspective from Michigan's EMS and Trauma Medical Director, Dr. William Fales. Dr. Fales is the Division Chief of EMS and Disaster Medicine in the Department of Emergency Medicine at Western Michigan University Homer Stryker School of Medicine. He's also the EMS Medical Director of Kalamazoo County Medical Control Authority. And Dr. Fales is really an essential leader and has been for the state's response to the COVID-19 pandemic. So welcome, Dr. Fales. We're looking forward to your presentation.
Well, thank you, and good afternoon, everyone. And Dr. Ray, thanks for that great presentation. Thanks for taking the time during what I'm sure continues to be a really hectic time here. Whoop. Yeah, okay, someone put my logo on there, I guess. I don't know that I did that, so. All right, can we go to the more boring one? Are you guys able to see that one now?
Do you want to share your screen and
run
that
your
own
help,
slides?
geez. Yeah, I think so, if you don't mind. I'm sorry.
Perfect.
I appreciate you putting
No
the logo.
problem.
I don't mind. Dr. Ray's slides were so so nice and graphic and multicolored, and unfortunately, I'm a loser today, so I didn't mine are like about as I don't think I've ever given a presentation boring. So so anyway,
we understand how busy you've been. So
yeah. So anyway, Dr. Ray, thanks for your time and the great presentation. You know, I think we often look to you and your colleagues on how cardiac arrest is done in the Pacific Northwest, and we try to take the best from that. I don't know that we ever envision trying to take some of the best lessons learned from during a pandemic, but we appreciate any information you can provide and for that great presentation. It was really interesting that we share the same motto, I think, for this response, which is trying to build the airplane while we're also trying to fly the airplane. And I think the only thing in Michigan we may add to that is we've been building it while we're trying to fly it, while we're also trying to decide if it's an airplane we're trying to build or a helicopter or a blimp or a rocket ship. I'm not sure what we're trying to build some days. So anyway, thanks for that. And I think everyone realizes here, particularly anyone that's in Southeast Michigan, you're going to hear some perspectives after my presentation just about how really devastating this pandemic has been on our state, and again, particularly in Southeast Michigan, and even more specifically in the metropolitan Detroit area and in the city of Detroit. What has not been often publicized is if you look at the death rate from COVID and you apply it to when the first cases were, using a point from where the first cases were in Michigan, you compare that to New York City. New York City's first case was on March 1st, and our first case was on March 10th. And so if we use that 10-day adjustment and then look at the mortality rate, at different intervals from the initial presentation, the death rate in the city of Detroit per 100,000 population is considerably higher than in New York City. And this isn't obviously intended to be a competition on something so morbid, but it really just shows the huge impact that the city of Detroit has had, as so many of you probably know. When we look at the number of hospitalizations on any given day, and we try to normalize that per 100,000 population. I wish I could have shown some slides, but always the focus of this talk. The Detroit hospitals have seen on at least 10 days during the peak more patients per 100,000 admitted than in New York City. So the point is really just that both cities did get it beat out of them pretty badly. So we had, I think, a record of reported of 179 people being placed on mechanical ventilation in the Metro Detroit area on one day. We had 1,490 patients on mechanical ventilation collectively in the Southeast Michigan Metro Detroit area, I think at our peak. And thank God the curve has indeed flattened, and we're kind of getting back into some degree of normalcy, but definitely a new world order. So my talk today is really focusing on what Michigan did in response specifically to sudden cardiac arrest. And I have, Terry, thank you for that nice introduction. Those are really my only disclosures, I think, for this talk, and no conflicts. I'd be totally remiss in not wishing everyone a happy EMS week. EMS is mission critical for our healthcare system on a good day, and has demonstrated amazing resilience and contributions in ways that we've never dreamed of. Like King County in Seattle, we have paramedics that have been doing nasal swabs. We put a protocol together on how to do a nasal pharyngeal swab properly. We have EMS units staffing hotels that are providing care to homeless patients. We've had, unfortunately, EMS contributing to helping with mortuary services in our mass mortuary operations in Southeast Michigan. We have investigated putting EMS into some of our prisons that have been so badly impacted as well, to help provide medical support to that vulnerable population. So again, happy EMS week from all of us at the Department of Health and Human Services. So very early on in the pandemic, we did at the state initiate a number of executive or emergency orders. We did executive orders as well, but emergency protocols. And these protocols, as Michigan EMS system is designed, for them to have effective law, have to be adopted by the local medical control authority. Most of the protocols have been adopted by the majority of our medical control authorities, or in the case of Southeast Michigan, they actually put in place some modified protocols that were even more stringent and I guess maybe a little more conservative in some of the interventions. But you can see a wide list of these protocols, and a number of these underwent multiple revisions, like Dr. Ray alluded to. This was kind of a changing, they were getting changing guidance from the CDC on what questions should be asked at the point of medical screening and system access at 911. So those had to go undergo multiple revisions, and that's just the way it is, I guess, during a pandemic. What I'd like to do, and these protocols are all available at the state website, michigan.gov/EMS, and you should be able to find those fairly easily. What I'd like to do is really focus particularly on one protocol, and this is hopefully a protocol that is known to most Michigan EMS providers. This is our emergency protocol for cardiac arrest in a patient with suspected or confirmed COVID-19. The protocol has undergone at least one revision to try and better realign our clinical presentation with the most current CDC guidance. And so we at the beginning of the protocol, we define who we're particularly trying to focus and who we are trying to suspect COVID-19 in. And that said, we certainly try to encourage all of our EMS agencies and healthcare workers on the front lines to, have a very low threshold to suspect COVID-19. With the stay-at-home order, we had some fear that patients or people would be, well, I don't have anything else to do. Let me just finish my bacon, egg, and cheese omelet, and then try out that treadmill that I've been wanting to use for a while. And then they have a sudden cardiac arrest. And, if they were on a treadmill, there's probably a reasonable chance they're at least not symptomatic with COVID-19, although we certainly have learned that there have been plenty of asymptomatic COVID-19 carriers. But we didn't want to throw the baby out with the bathwater. We wanted to make sure that the knucklehead that is working out for the first time on the treadmill would, after his bacon breakfast, would in fact have the benefit of a respectable resuscitation, balancing that always with importance of workforce protection. This is just excerpts out of the protocol. I've shortened them a little bit to make them presentable on the slide. In the protocol, we were able to get it down to a one-page protocol, so it's not real involved. There's just a reminder of the importance of personal protective equipment. Don't blame me when we had the shortage. It wasn't really always my fault for that. We tried, and I can tell you that on every push out that we had of the Strategic National Stockpile that Michigan received, EMS was a visible component of that. And I'm not aware of any push that went where there was not consideration for, it might not have been as much as we wanted, but we did realize the value and the importance of EMS. So those questions on that previous slide, the signs and symptoms, I don't think we've ever, from our first CPR class, ever been trained to walk into a situation. We always evaluate scene safety, but we don't, before we begin resuscitation, we don't ask about foreign travel and what types of sniffles and colds and man colds and hyperman colds people have. We dive in and we say that's a patient in cardiac arrest, and we dive in and aggressively begin resuscitation. From a PPE workforce responder safety perspective, we really need to be able to approach cardiac arrest as if they could be COVID, and our personnel should be presenting with proper PPE. And I would completely agree with Dr. Ray that that the majority of our cardiac arrest did not appear to be COVID directly related to a COVID infection. So we wanted those other cardiac arrests that occur, whether you're having a pandemic or not, to receive good resuscitation. But again, initially in those first few minutes of the first responders' arrival, until you can get more of a history on the patient, approach it as if it was a COVID-19 patient. And even if you do get a negative history, really, I don't think we were encouraging anyone to relax their PPE or their precautions. Our protocol then dives in the bottom half of that is on the treatment, and basically from a clinical perspective, if there's no indication that they had antecedent clinical symptoms of COVID-19 as at the top of the protocol, resuscitate as usual and work the arrest as you usually would. For patients where this COVID-19 was suspected, or even in some cases confirmed because they might have been already sheltering in place after a positive test, the protocol was basically continue to follow our cardiac arrests with the exception of the following. And we made a decision, and it was vetted through a number of kind of trusted colleagues as medical directors, but in the state protocol to eliminate an oral endotracheal intubation and instead stay with BLS. And for Michigan, BLS airways include optional use of supraglottic airways. And the rationale for that was, really to try and mitigate exposure risk of the paramedic or EMT performing the procedure. For intubation, obviously the paramedic. And the supraglottic airways in our system have had a very high first pass success rate. A number of our agencies and medical control authorities have adopted those as first line cardiac arrest airways. And the beauty is up close and personal as you would with direct laryngoscopy, and even for some of the few services that are using visual laryngoscopy. So that was there was a lot of discussion about that. At the end of the day, the airway itself, supraglottic airway, may not be as good at mitigating the release of the associated spew with the ventilation as a cuffed endotracheal tube. But that was the decision we made. I talked to some medical directors in some other states, and they've adopted some similar practices. you know, just a safety precaution of limiting personnel to the minimum number needed for the resuscitation. Keep we still want, you know, high performance pit crew CPR, but the team can be loosening up out in the next room, not in the room with the patient. Try to keep as much of a 6-foot distance as you can if you're not directly involved in the resuscitation skills. Probably one of the more controversial components of this treatment protocol was consideration for premature termination of resuscitation. If no ROSC was achieved within 10 minutes of, then paramedics were directed to contact medical control for possible termination orders. And part of what informed that policy was we tried to pull together some information very quickly from pre-COVID days. We're looking at both the statewide EMS information system and our statewide CARES data. And unfortunately, those are not linked together well. The CARES data has really wonderful outcome data. The EMS information system has a lot more granular data on things like fever particularly. So what we looked at was, we looked at historically over, I think it was the last 2 years or so, Terry might correct me if I'm wrong. We looked at our cardiac arrests, and we just did a keyword search for the word fever, and then kind of quickly made sure that in the narrative it didn't mean a pertinent negative of no fever. And so with the subset of patients, it was a very small number of cardiac arrests where fever was mentioned in the narrative, but we were able to identify those where it was, and then we did our best to try and manually kind of crosswalk those to the CARES outcome based on the county and agency and some other common factors. Again, we had very small numbers, but what we found was not very surprising, was that if you have a cardiac arrest and it's associated with a fever, and that would typically be like a periseptic type of an arrest, you know, unfortunately don't sell that patient life insurance. That's not likely to have a good outcome. And we found only a couple of survivors in that group, and was far less than what we would normally expect in a cardiac arrest group that would not have fever. So that gave us a little bit more comfort in including that early termination clause. Do not transport patients while in cardiac arrest. And for a number of medical control authorities and EMS systems in our state, they've adopted a protocol where we generally don't transport until we have ROSC. And if we don't have ROSC, then we tend to terminate in the field and not transport anyway. So that wasn't, for many services, that wasn't a big deal, but for others that was. And essentially before moving the patient to the ambulance, we wanted to have sustained ROSC, which we defined as a continued palpable pulse and blood pressure above 60 at least for over 5 minutes. And if you, otherwise it was a field termination. And even if systems have mechanical CPR, we felt that it was inappropriate to transport failed resuscitations to the hospital, exposing others. And really, I would argue that probably one of the most dangerous places in the entire healthcare system for a clinician is in the confined space of the back of an ambulance. There's not anything else that I can really think of that is that tight and that, you know, limited, as that limited ventilation. So that was the rationale for that. Finally, the protocol. Yes.
Oh, this is Terry. I'm just giving you a warning to wrap it up because we have a lot more speakers to cover.
I'm sorry
to rush you.
I'm sorry, no problem. Okay, 5 minutes? Or are we out of that?
Like 3 minutes. We're pretty much out of time, so.
Sorry, yep,
sorry.
Okay, got it. Nope, Terry, that's all right. You've cut me off before. Usually you're able to like throw something physically at me, so that is an advantage.
I know.
All right.
Why don't you wrap it up with some of your closing thoughts? Yeah.
Yep. So what we found here, let me go to some, I'm going to pass this out. You'll get copies of these slides, right, Terry?
Yes, yep.
Yeah, we'll get the slides. So this is what we found looking at the data, and I apologize for going long. All right, so what we found was that we looked at a 45-day period comparing March 15th to the end of April, so 45-day period. What we found was statewide, our cardiac arrests increased by 33%, which was a little surprising. We also found that, but in the 5 counties that had the highest death rates, Southeast Michigan, particularly including Saginaw and Genesee County, the cardiac arrests decreased by 50%, paradoxically. We're not sure exactly why that has. These are cardiac arrests reported in the EMS information system. We found very similar rates of bystander witnessed cardiac arrest. Bystander CPR rates were very similar in both years, and we saw a drop in the AED use, particularly in the high impact areas. And that, I think, most likely is reflecting the fact that we were in lockdown in public places where EDs were located, were shut down. We found arrests with shockable rhythms of presumed cardiac etiology increased statewide by 37%, and in the high impact counties, even a little bit more, 40%. The thing we worry about there, and Dr. Ray alluded to this, was people sitting at home with chest pain for fear of going to that COVID ER and getting a workup, and sooner or later that may have, they had the big one and they had a VF arrest. So that was kind of surprising. And well, not surprisingly, we saw a pretty significant reduction in intubations, ROSC, and transfer, and sustained ROSC. And so this is based on super preliminary information. I think if you see the slides, if you go through that, the slides will make sense. The slides are again from our EMS information system that were analyzed using biospatial. I think the percentages are probably reasonable. I think the absolute numbers may reflect some dual responses of ELS and ALS, but I think interestingly, there's some trends that definitely deserve further review. Terry, thank you for being so gentle and not throwing anything at me virtually. I know you were probably trying. So
thank you, Dr. Fale. Yeah, yes. Thank you so much. No, it's so interesting to hear what's happening in Michigan. We have been hit very hard. So thank you. And please stay on the call because we'll have some questions for you after the next 3 speakers. So I'm going to introduce the next 3 speakers right now and then let them go into their presentation to help with time. So the first speaker will be Ron Slagell. Ron is the president and CEO of Emergent Health Partners, which includes Huron Valley Ambulance here in Washtenaw County. And Ron has spent over 30 years in pre-hospital emergency care. We're also going to hear from David Feldpausch, who is the EMS director for Livingston County. And David has extensive experience as a paramedic and in EMS agency leadership roles. Then we're going to hear from Todd Horner, and Todd is the administrator supervisor for Livingston County EMS. Todd served in the Navy as a firefighter and then continued as a firefighter paramedic in South Carolina. He's been proudly serving the citizens of Livingston County for the past 18 years. So first off, here is Ron. So Ron, welcome, and we look forward to your presentation.
Thank you very much,
if you'd
Terry.
Like to share your screen.
Yep, glad we can be here with everyone. So just wanted to give from a provider perspective some of the things that we encountered during this pandemic. It's certainly been something we never expected in our careers. We'd always trained for pandemics and other multi-casualty incidents, but I think this one exceeded and extended well beyond anything we'd ever really encountered. And so if we can get the screen to advance, there we go. So just as a perspective, Emergent Health Partners is made up of 4 nonprofit community-owned ambulance services, including Huron Valley Ambulance, Jackson Community Ambulance, Life Care Ambulance, and Moreau Community Ambulance, and 2 others in Lenawee and Albion as subsidiaries of those, but extending really across the I-94 corridor, representing 1.1 million residents of Michigan get one of our paramedic ambulances when they dial 911. So we have a very large geographic service area, and it was interesting perspective because we had some of our counties right in the hot spot of the COVID pandemic here in Southeast Michigan, and others in Western and Central Michigan that were not nearly affected as significantly and severely. So certainly one of the impacts that we saw, and Dr. Ray referenced this as well, is we certainly saw decreased call volumes. Unlike some of the other communities where there had been outbreaks, we really did not see the big spike in calls related to COVID. What we immediately saw, and I'll show some graphics related to that, was some market decreases, up to 35% on a weekly basis of decreased call volumes, both on emergencies and transfers. We certainly saw a higher use of personal protective equipment and more time involved on calls as we use that when we cared for the patients, and subsequently then when we clean and sanitize our vehicles, continuing to keep our employees safe by wearing PPE. And that was something we really had to monitor and carefully observe the amounts that we had available for our staff. We did obviously have to monitor the COVID infection of our employees. We have over 900 employees in our organization, of which probably about 600 or so are clinical providers, and we have a very low rate of infection of our employees. I think we have encountered 8, including clinical and non-clinical staff, that have been exposed to COVID. Most of those have been very minor cases compared to some other hospital and other healthcare workers that have had a more significant illness, or in some cases, unfortunately, for fatality. But I think the extensive use of PPE in EMS, as well as the ability that we have that we don't encounter that patient for a very long period of time, I think helps minimize that exposure. And as Dr. Fales also mentioned, we had a lot of protocol changes, both on the emergency protocol side, which was actually helpful to have statewide protocols, although we're having some challenges now. Is we operate in 12 medical control zones, and most utilize a regional medical control perspective. But one of the challenges we're starting to have now is individual medical controls are now tweaking those state medical protocols and getting away from more of a regionalized approach. So that is starting to create some new challenges. Dr. Fales also alluded to what was happening in our cardiac arrest situations. And that did change some things, specifically in airway and breathing treatments for patients that aren't in arrest yet, but that changed as well. So we certainly had things that our paramedics had to learn on the fly, and I give a lot of credit to them. There were a lot of information we threw out at them on a very frequent and rapid basis, and they adapted very well. The other thing was the additional screening questions that were that needed to ask related to COVID, so we could advise our responding EMS units whether there was potential for a COVID response or not with the patient they were encountering. And then there were some changes in scene interactions, and that was included limiting the personnel that enter the scene, so that we would try wherever possible to have one person encounter a patient that might have exposure to COVID, so we could then ascertain the situation and minimize the number of first responders and EMS personnel that might be have potential to be exposed. And obviously included entering the home. Usually we did scene safety as paramedics and EMTs, but now our scene safety might be from further away, and from further assessment that we weren't normally doing to might ascertain if that patient might have COVID or COVID symptoms. I think we also encountered that we paramedics took less equipment into the patient and left it in the ambulance because they found that by taking that in, especially for patients that were not transported, then there was significant downtime in having to clean all the equipment that was not needed to be used there. So I think there was more emphasis, not necessarily intentionally by protocol, but I think that's what we found practically is crews did that as an adaptation. I think facility screening was something that we really encountered some challenges with, whether these facilities were skilled nursing homes or hospitals. Especially at the beginning, every facility was using different facility screening processes for their personnel and for our personnel as we entered those facilities. That included temperature screening, of course, and in some cases we had skilled facilities asking travel history of family members or friends of the paramedics and EMTs. So in one case, we had a paramedic denied entry into a skilled nursing facility on an emergency call because they had someone who had visited them from New Zealand within the last several weeks. I would certainly understand if they visited from China. But the challenge there got to be that there was no consistencies. So an employee would be screened by a hospital, and sometimes within the same hospital, and they would do an interfacility transport. And then even though some of those hospital systems had created a system by stickers, color coding, different methodologies to alert the incoming facility that that patient, that employee had already been screened, we were re-screened once again. And we also had problems, like I mentioned, with being denied entry to certain situations. So that created a problem, especially during the first several weeks. So I did want to share some information regarding ambulance transports that were related during the COVID outbreak. And as you can see at the far left of the screen, as soon as Michigan started having cases, our call volumes immediately dropped. Matter of fact, you could make the case that our call volumes started dropping for emergency calls even before Michigan had its first case, when we were seeing it elsewhere in the country. I think people started to be fearful right away. As Michigan daily COVID rates increased and peaked, that's pretty much when we bottomed out for the number of emergency responses per day for EMS for emergency calls. And then as you can see by the yellow line, we've had a slight but not very large increase in the number of calls for emergency requests that have continued to go forward. We have continued to promote, as others had, the safety of using EMS and emergency rooms when you're having a true medical emergency, and hopefully that message by us and others will have some benefit. Here's just a slide showing on a daily basis the number of interfacility COVID positive transports we've done. As you can see, that peak occurred in late March through late April, and fortunately has declined very significantly. I've also indicated there the number of patients in those interfacility transfers. About 37% of those patients were ventilated patients when we did the EMS transport. Of particular note to this group of individuals on the webinar was our EMS responses as it related to cardiac arrest. So as you can see, when we compared for January through April of 2019 versus 2020, the number of cases where the patient was dead prior to the arrival of EMS has increased very significantly. And this is concerning, and it's been reported across the country, and our data validates that as well. Matter of fact, this slide really shows the change in that. If you look at the month of April, when COVID was at its peak here in Michigan, the dead prior to arrival by EMS increased 38% over the prior year. And that was obviously that message of folks, we believe, waiting too long before they called for help, and unfortunately were dead before EMS arrived and we weren't able to assist them. The other good news here is that the pandemic is easing. This shows from the blue to the orange to the gray over the months of March, April, and May, the number of calls that we receive in our 911 calls that our telecommunicators receive, where the patient reports both shortness of breath and fever. And let me stand corrected, this is actually off the patient chart. So this is actually after the paramedics have assessed and treated and transported the patients. So patients with both shortness of breath and fever has declined substantially on a daily basis going forward. So it's been an interesting challenge. I think we'll have lots to learn going forward, but I just wanted to share a little bit about my provider's perspective. And with that, I'll turn it over to David.
Thanks, Ron.
Good afternoon. I have a little bit different perspective, but many of the things I'm about to say are very similar to what Ron just told you. I came into Livingston County as a brand new employee, new to the area on January 6th. So I came right in the heat of this, trying to learn a brand new EMS operation, and COVID fell in my lap. So I'm going to skip through a bunch of the beginning of my slides in the essence of trying to save some time, but just kind of getting into the meat of what my presentation had. Determining appropriate PPE and how to acquire it was a real challenge, especially as supply chains didn't seem to hold up as well as they should have. Looking for alternate reusable types of PPE, determining what you can decontaminate when and how, and reuse that. And I had many of the same facility issues that Ron mentioned. Different requirements to getting in and out of every facility created some real significant challenges for us. Lots of updated protocols and procedures. Last time I counted, there were 15 protocol changes, And I know we had multiple times in a day that different protocols would come out. Not mentioning that as a bad thing, just trying to wrap your head around the speed of which it changed for EMS providers. Lots of changes in the rules and regulations, requirements on how EMS could operate. We chose not to implement any of the altered standards. The impact here in Livingston County is significantly different than a lot of the other places that were actually quite rural. As of today, Livingston County only had 385 confirmed cases and 26 deaths. So when I looked at that, we transported, I believe, 44 COVID positive patients throughout the entire pandemic. So the impact on us has actually been very minimal. It's been managing the rest of everything that goes around COVID that's been much more of a challenge. Let me get to that page. Biggest challenge for us is this screen right here, and that's managing the fear. This whole thing has came on to all of us as an unknown. So how do we combat the fear? Regular updates to our staff, sharing facts, trying to sort the facts out of all the information that tends to be out there. Not being afraid to say occasionally that we don't know, but we'll find the answers. A lot of the answers weren't out there when we were first starting our COVID response, and we were literally learning and making answers as we went. Quickly developing follow-up processes with feedback from the health department. That was really important to all of our crews, that we got feedback on if their patients that we just had contact with were or were not COVID positive. At the end of the day, I believe we only had one documented exposure, and we've only had one employee that resulted in an infection, and they're not the same employee. Now that's out of about 100 employees. So we have about a 1% infection rate. That one infection we could not even trace back to make it an EMS related issue. So we don't even know that it was contracted as a part of his job. That kind of goes back to a testament to the great job that our employees have done adapting to all of the changes, utilizing the new PPE, their disinfecting techniques, and adapting to all these changes very rapidly and doing so very well. Biggest result for us, this screen right here sums it up: boredom. By the time we actually had all the pieces in place, we were ready for COVID to hit. We were sure of it. What happened for us was absolutely nothing. Our run volumes dropped 20% right off the bat. That's back in February, 38% in March, and now we're down in May, almost 48%. Despite our efforts to try to convince the public that it's safe to contact EMS and to go to your hospital and your doctor, they're still not calling. So now we kind of moved our focus onto looking at non-traditional opportunities to help our community, because we didn't have really anything significant COVID to respond to. We're looking for other ways that we can have a positive impact in our community. Many of the same ones that Ron mentioned, we've kind of stepped up and offered to volunteer with the MIMORT and transporting some of those folks, trying to help out with Department of Corrections. And it seems like every time we get to somewhere where we're going to make an impact, that goes away. So boredom is still probably, boredom and fear are our greatest challenges operationally. Preparing for the future. Obviously, we're now in that phase where we're starting to look backwards and see, okay, what did we do? How well did it work? We're all preparing for a second wave of COVID, so we're trying to figure out what that's going to mean for us. Looking at the things we wish we could have done better. Looking at supply chain stuff now that it's opened back up. What do our inventories really need to be? Probably a little higher than they were before, so we're better prepared in case we see that rebound spike. Planning education to better prepare staff for the future. One of the other things that we saw that was significant, and I need some more time to run the data, but like Ron had mentioned earlier, they saw a 38% spike in out-of-hospital cardiac arrest. In Livingston County, in the months of March and April, we saw a 238% increase. That's huge. That tells me that there's way too many people that are sitting at home following the orders, but yet scared to use the medical resources that were there to them. We should never see that kind of spike. So I hope we look at how we manage the consequences of what we've done in our COVID response, as well as just the response itself. And with that, I'm going to yield to Mr. Horner, who can certainly tell you much more about our physical COVID response than I can. Thank you.
Thanks, Dave, and good afternoon, everybody. Everybody hear me okay?
Yes, Todd. Welcome.
Just kind of piggybacking off of what Dave was saying, you know, we had the ultimate response. And the best perspective that I can provide is what we've pretty much done and as far as our resilience goes. So we talked about earlier about the changing landscape, you know, an entire new section of protocols. This kind of, you know, was pretty impactful to our crews, just because of when you add an entire section with 15 new or 11 new protocols, and it was essentially, it happened overnight. So we had to adapt to that. And as leaders, we just kind of looked to each other to say, you know, how are we going to handle this? And with all this information coming in, our building became essentially a supply warehouse for a strategic national stockpile. And we just all rallied together. And, you know, I would say a quarter of our garage, which houses 32 ambulances, became essentially a FEMA warehouse for the strategic national stockpile for District 1. And it actually worked pretty well. We were getting deliveries 2 or 3 times a day. And it was just an adaptation. And the other thing was, you know, 90% of our administrative staff is working from home. And working from home in EMS, who would have ever thought? I tell my friends and family and coworkers, you know, about working from home, and they're like, "But aren't you a paramedic?" It's like, yeah, but you know, so you have to adapt to the changing situation, and that's exactly what we did. So, you know, equipment, supplies, and logistics. There were really no new modifications in any of our equipment. Just an added layer of protection and deviations that we were experiencing. And like I had said before, we had to be acutely aware of what our PPE was and the potential for shortages. And it was kind of like a hurricane. You know, you get the front end of the outer bands, then the eye comes over, and then the back end of it. And the back end never really came around. So we were definitely prepared. Supply tracking became a little bit overwhelming just because we didn't know how much supply that we were going to get or not get. You know, our supply vendor, we stay up on our supplies. And then all of a sudden, you know, you go onto the website and everything is not available. So that could have been pretty disheartening, but we were diligent and we had to make a plan. And when we developed the plan, we implemented it and we moved forward. So the new norm became of conservancy of PPE, being acutely aware of your surroundings and tracking and tracing of what you needed, because I felt like if we gave in to the fear of media, social media, and everything else, we would have failed. But internal measures, our strong leadership is what really kind of put us to the forefront and is really what kept our employees safe and healthy. The front line has really adapted, I think, pretty tremendously. And it's kind of ironic that we're having this meeting this week that, you know, this is EMS week, and we're celebrating, you know, the work that we all do pre-hospital wise, and the boots on the ground have just been tremendous. I talked about putting our plan in action to ease the tension. our morale and our motivation has been extremely high because the call volume is low. We're healthy. That's another good thing, is going home and not taking it home to your family and being able to come in work and work remotely. That's a very big advantage versus being unemployed. And the information was consistent, but positive, but not COVID positive, right? And overcoming the fear with success became a new normal. So what we did is, in our adaptation, was our crews, one in particular, our education supervisor and one of our employees, our crews were overwhelmed, especially with pre-hospital cardiac arrest now and the changes and what do we do. So we have an employee, his name is Jack, and we developed the fun facts with Jack. And unfortunately, because of the technical piece of it, we weren't able to play the video, but we took some snapshots of what Jack was able to convey to the crews in a kind of a humorous but methodical and very caring and educative way. And it's been a huge hit. And our crews have just really been able to kind of absorb all the changes without it kind of put in your face of like, read the protocol, and it's kind of like a visual learning. So the web link there for the YouTube channel is down there if you want to take a look at it. It's about a 4.5-minute, 5-minute video, and this has really kind of launched a new education initiative in our department of a way we're going to change and do some education to kind of get to bridge that gap. But all in all, as an international incident, it's been not fun, but globally and prospectively for local, our department and our agency, I think we've adapted really well, and our resiliency moving forward is what's gonna get us through this. So thanks for listening.
Thanks so much, Todd. Thank you. And kudos to Jack. So we got to watch his videos. They're very cool. So thank you also to Ron and David and all of our other speakers today. And now we're going to take some time to address some questions that we have from the participants in the chat room. So Stephen just put up a slide there to how to use chat. But the first question is for Dr. Ray. Dr. Ray, if you're still on the line and can hear me, one of the questions was, you had mentioned you instituted tracking policies for employees exposed to COVID-19. Who manages that tracking for multiple agencies for your state?
So yes, Terry, I'm still on the line. First of all, let me commend Dr. Fales and all the other speakers. It's really very interesting to learn and to listen. I think there are common themes across the nation in terms of EMS and trying to keep the whole system operating. And I would say EMS has really done a tremendous job taking what I would call an integral role in trying to deal with the pandemic. So back to the question. So this activity is really specific to King County. And so each fire department has a health officer, and that health officer is on point. And we made it very clear to the fire chiefs that this person is going to have to be accountable. And so we have a web-based platform that they use to, anytime someone goes into quarantine, they register them, and then that person gets a ping twice a day to register their symptoms. And if they develop symptoms, then they're directed to go and get tested for COVID during that 14-day quarantine. So we have a centralized web-based platform, but it really relies on health officers from each of the fire departments to be accountable and to activate that platform.
Great, thanks. Are you using any apps? Is it an app? You said it was web-based?
Yeah, so I would say no. We do send, it is electronic, web-based, but it's not been condensed into an app form.
Okay, great, thank you. Our next question here is for Ron, Todd, or David. Given that many of the non-emergency procedures have been canceled for individuals who require transport by EMS, Are you concerned about a surge of non-emergency calls once we open up the state and the pandemic is over?
So I guess I'm not so much concerned with a surge, because I think there'll be increased demand, but it's opening up slowly. And actually, even some of our hospital systems have already announced that they're taking patients, but yet our call volumes are so far going up very slowly because the public still, as Todd pointed out and David in their presentation, I think they're still fearful. So as that goes away, I think we'll see that increase. So we're not so much concerned with a sudden surge, because the capacity of the outpatient and other treatment facilities has had to change as well. They can't take as many patients and rush them through in the normal patterns. This is going to really be a reset of our healthcare system.
Right. Yeah. You guys have really had to adapt on the fly. Dr. Fales, we have a question for you. What is or should be done by EMS agencies to prepare for a second wave of COVID patients as things begin to open up in our state? And then if you could touch a little bit upon is anything happening special related to COVID now that Midland has experienced this disaster with flooding?
Sure. I think probably one of the most important things for all of us to do at the agency level, med control level, hospitals, and for the state is really to take some time. We're probably getting pretty close to where that should be being started, if it hasn't already, and to look at what worked and what did not work well during the last couple months. And I think certainly capitalizing on the stuff that's worked well and retweaking and adjusting the stuff that did not work as well as we wanted. So I think we can really do that at kind of all levels of a response. I think that's the best way to really prepare for what we hope and pray will not be another wave. But we definitely can't be caught off guard this time. I think the other, as far as the Midland component to this disaster, so right in the middle of a pandemic, we have a 500-year flood that compromised a hospital with 100+ patients in it that could have been absolutely awful. Also, of course, with a major Dow chemical plant right down in the floodplain. So I'm guessing tomorrow there'll be a herd of locusts coming in to descend on Michigan. I think we have
Hope
left.
Not.
So I'm not sure. I think that, fortunately the State Emergency Operations Center was already activated and we were able to respond maybe a little quicker than we would normally. But at the state level, I think it's probably hopefully going to have a minimal impact out of the area. I think our state's robust enough to be able to manage multiple different types of disasters at once, unfortunately.
Okay, great. Yep. Thanks. Dr. Ray, are your telecommunicators, when they're doing the bystander instruction for CPR, are they now suggesting using a towel to cover the patient's mouth? That was one of the questions. And then another question is, can you highlight any protocol changes for EMS or fire regarding the treatment of COVID-positive cardiac arrest cases in King County?
So sure, Terry, happy to respond. So no, our telecommunicators do not ask any of those questions. We treat cardiac arrest on the level of telecommunicator and on the level of EMS as we always have. We with the exception that EMS treats all cardiac arrest as potential COVID, because we don't have the luxury of time and often a good history. Given how sensitive we are to taking action quickly. So in those situations, again, the telecommunicator uses their conventional 2-question approach and then coaches the bystander to do compression-only CPR, which is what we've always done. Yeah, we don't ask questions about COVID risk, and we don't direct a mask or a cloth. And then EMS just uses full PPE on anything that's a cardiac arrest. It's only it's only 1% of our calls, so it's really not a sort of a resource issue. And we just don't want to take the time to try to determine history in that situation. And so they just don their PPE and maintain it for the course of care.
Right. So for Ron or David or Todd, do you know in Washtenaw, Livingston County Dispatch, or were they asking questions on to determine cardiac arrest if the patient had a fever or a cough or known COVID? Did that become part of your script?
I know we did ask those questions of all callers or of callers. I'm not clear if once we determined that was a cardiac arrest, if we deviated from that or not. I believe Kevin Irwin, our VP over communications, is on the line. Maybe he can address that.
Yeah, Terry, we did not alter from the cards at all. All we did was make sure that the first responders were aware that we had a positive screening to take all the precautions. And then we went forward with our standard protocol pre-arrival instructions.
Okay, great. Thanks. Another question here. Dr. Ray emphasized EMS collaboration with public health. To what extent is our local EMS collaborating with our local public health here in Michigan? Who would like to answer that? Maybe Dr. Fales?
Sure. I think it's, not surprisingly, it's pretty variable. I think we have some places where we have like model best practices being taken place, and we have other places where there's probably a more significant disconnect. I can tell you a number of discussions we've had with like local public health, where one example was a need for basic medical staffing at a hotel with a large number of COVID homeless patients. And the public health nurses they didn't have the capability in terms of the resources to do that, and they were kind of like trying to find hire contract nurses or whatever. And we kind of said, how about EMS? And it's like, wait, EMS could do that? So that like the light bulb clicked, and EMS took over the whole operation. And so I think that was really what I would consider really a best model. I mean, they give a regular report to local public health, but they run the whole operation from intake to discharge. And so that was something we've never really planned for in our before. So good example. Also, the prisons was another example where I think a lot of times we just don't, once public health knows what EMS can do, it's a resource that they really haven't considered. And most of us are not fortunate like Seattle and King County to be embedded within the local public health department. That just happens to make has to make a better.
Right. Another question is about touching a little bit on the interaction between law enforcement and fire and EMS during this pandemic. I know the Resuscitation Academy out there in Seattle put together a handbook for law enforcement. I think they actually asked for some guidance. So who would like to take that question on the interaction between law enforcement and EMS? Anyone?
This is Dave. Well, I can address it locally from Livingston County. Almost since the very beginning, we started, actually before we even had our first case in Livingston County, we started doing daily meetings, most of them Zoom, who figured, and a local law enforcement, health department, fire. We've been on these calls, probably 50 or 60 of us almost every day since this thing started. So we've had seamless share of information at the management level from this thing from the day one at the local level. I can't speak to how well that happens at other counties, but that's what's happened here.
Okay, thanks, Dave. I'm going to do one last question here, and then we'll have to wrap it up. The question is, what protocol should we be using for cardiac arrest going forward here in Michigan? Still pronounce after 10 minutes of CPR, no ET tubes. Dr. Fales, maybe as EMS director, you'd like to answer that? Sure.
So I think there's definitely going to be things that will be done different from this point on for the long haul. I would, the 10-minute termination, I would remind you, that's only for the COVID, highly COVID suspected patients. We've had a number of really nice resuscitations after 30 or 40 minutes over the last month or two in some different areas of non-COVID patients. So it's so important to remember we're talking about the patient that presents with known COVID or suspected COVID. I think it'll be interesting to do an analysis in places that have been historically using endotracheal intubation, can take a look and see how things have done with using supraglottic airways. Like I said, we have many agencies that do that normally as part of their routine. We'll see how that goes on down the road. But I think this is a good opportunity to look and see what's worked and what hasn't worked.
Great. Thank you, Dr. Fales. Well, thank you everyone today for joining us. I just have a couple announcements before we end the meeting here. I know there's a wider audience on this meeting today, but I wanted you to know that the next Learning Community meeting is June 18th for people who live and work in the Washtenaw, Livingston County area. And Save My Heart, our annual meeting, will be a webinar this year. It will be on June 12th from 9:30 to 12:30 p.m. Eastern Standard Time, and you can check the Save My Heart website for the agenda and registration details. And I just again want to thank all of the diverse group of first responders, EMS leaders, and hospital providers, law enforcement, everyone who joined this call today. It was just very enlightening to listen to all of your experiences and insights on what's happening in our changing communities given this COVID pandemic. So thank you all very much today. Have a great day. It's Memorial Day weekend, so be safe, and I hope you can enjoy yourself a little bit over this extended weekend. Thank you so much for joining today. Goodbye.
Thanks, Terry.
Bye. Thank you for joining. Bye, everyone.